Welcome, Paul.
Thank you. It's great to be here.
So when your company announced that you're shaking up your PBM structure, it was pretty fascinating to me, and I wanted to get a little more deeper into why you wanted to do that, because, you know, on the outside, us journalists had heard stuff from folks that PBMs are the middlemen, you don't necessarily need them, so on and so forth. And of course, the PBM industry says, of course, we serve, our stakeholders really well. So we thought, and of course, the FTC is scrutinizing the large PBMs. So in that vortex of news and information, and maybe some misinformation, I thought it would be good to sit down with you and ask you what motivated Blue Shield of California to go down this path.
Sure. Well, I'll just step back. I mean, we're a nonprofit health plan, and we're very much driven by our mission to create a healthcare system that's worthy of our family and friends and sustainably affordable for everyone. So God forbid one of your loved ones needs to access the healthcare system. First of all, they can afford it. They can. And secondly, they get treated like you'd want your loved ones to be treated at their time of greatest need. And not because we know people and can call, but it happens that way every time for everyone. What we've noticed is that the gap between how the world works today in healthcare versus that aspiration is really large, and there's no way to get there incrementally. That's not just with pharmacy. I mean, it's across the board. I was telling someone before, we keep fax machines in business for some reason. So there's all kinds of things that need to take great leaps forward and be truly reinvented and reimagined. And that's what we looked at in the pharmacy world. I would say one of the big lessons I've learned in my more than 2 decades in healthcare is that you cannot fight self-interest. And that you have to pay people and have them earn their revenue and their profit to do the things you want them to do to make healthcare more affordable, higher quality, a better patient experience. When you do that, you get more of that. When you pay for more days in the hospital, you get more days in the hospital. When you pay for more services and appointments, you get more appointments. I mean, it's pretty simple. People follow the incentives. Mm-hmm. And when you look at the pharmacy system, the fundamental problem is the incentives. You know, there's about 8 players in the middle between a pharmacy manufacturer and the patient, and they all get paid. They get more revenue and more profit when we sell a higher volume of more expensive drugs. Mm-hmm. And so that's just structurally inflationary. And when we looked at the trends, we were saying, well, they could be in or around 10% a year for years, just for the foreseeable future. And there's just no way. There's no way you can get to sustainable affordability with those trends. And when you're sitting down having arguments like we had with our pharmacy benefit manager, where there's this prostate cancer drug called abiraterone that is generic. It costs about $3,000 a month. Through Civica, which is a nonprofit group that we helped form, we negotiated that same compound, it's a generic, for $160 a month. So then we said, great news. And we went back to our specialty pharmacy and said, great. Our pharmacy benefit manager said, let's go sell the $160 drug. And they said, no. I mean, and they kept coming up with these reasons. I don't think they ever said that the dog ate their homework, but it came close to that at different points. Like, there's just sort of ridiculous reasons why they couldn't do it. And they finally allowed us to have access to it. But even as of a few months ago, the last time I checked the data, most of the major health plans, including United Healthcare and most of the Blues, have access to this $160 version. Mm-hmm. There's 90% share for the $3,000 version. It's the exact same compound. Why? Mm-hmm. Because everyone gets paid more money, including the pharmacy benefit manager, including the specialty pharmacy, when you sell a higher volume of more expensive drugs.
So your PBM was Cigna Express Scripts, correct?
No, CVS.
CVS, sorry. So yes, you're right. You moved away from CVS. I apologize.
Yeah.
But if they agreed to do the specialty drug for you, eventually they agreed to, right?
They agreed to let us do it through our own specialty pharmacy.
How generous of
them,
I guess.
Yes.
So why bring in these other groups then? What do they give you that CVS?
But the basic idea is, instead of having this Rube Goldberg contraption between the member and the and the pharmaceutical company, where there's literally like more than a third of the cost of the drug, or the list price of the drug at least, goes through this distribution system. We said, well, just forget about that. Start over. We'll go to the pharmacy manufacturer and say, we have no interest in you paying us any fees or any rebates. We just want to pay you for the drug.
Okay.
And you're going to get the exact same amount of revenue that you had before, right? We're not trying to reduce the amount you get paid. We're just going to pay you that amount of money, and we're done.
Okay.
Then the question is, how do you get the drugs, the right drug to the right person at the right time? Well, now we want all the players in the system to have motivation and incentives to get the right drug to the right person at the right time in the most cost-effective manner possible. Who does that really well? Amazon.
Okay.
We want the pharmacies themselves, the retail pharmacies. We just want them to get paid, like on a flat fee. Like maybe there's a cost plus. Oh, who does cost plus? Right. So, and then we had to find a pharmaceutical claim system that could actually process claims without rebates, which is a lot harder than it sounds because the whole system is based on these rebates and fees. Turns out Abarca has really designed a system to do that. So we went through a really detailed request for proposal process where we broke down all the things you have to do to get the drugs from point A to point B and fulfill it. And then we took each of the pieces and bid them out, and we said, no, we're not bidding this as a package. We're just bidding them out. We found those that were philosophically aligned and had the capabilities, and we signed them up.
But CVS Health said, not much big of a deal that you guys did this because specialty drugs is still with them, and that is what drives healthcare costs, right?
It is.
What do you say to them?
Well, I mean, that's fine. We're not doing this to impact somebody's profits. I mean, that was never the motivation. The motivation is, how do you create a healthcare system worthy of our family and friends and sustainably affordable? And who is the best for our members at doing that piece of it? CVS is doing a very good job on specialty. Now, you could imagine that the contract we signed with them this time around is not a lot like the contract we signed with them that we had before.
How so?
Well, I really can't go into details, but it would be reasonable to imagine that if we were to do something through Civica, like we did this last time around, that we would have the absolute right to make sure that that gets distributed immediately once we have access to the price, as an example.
Okay. So what does CVS Health do well in specialty drugs?
Well, first of all, when you just look at customer satisfaction, it's really high. The second thing you have to understand with specialty is actually the timing, getting some of these drugs have to be treated very carefully in terms of their temperature control. They need to be there at the time the member's there for the treatment. You can't be like, we were a few hours late. Whoops. So this is a pretty complex place, and it's actually a place where some of the new entrants haven't gone yet because it's some of the more complex administration of drugs. And so there aren't as many alternatives in special. I think that's going to change over time, but right now that's not the case. But the customer satisfaction was really high, and they just do a nice job on the logistics of getting them there. So that's why they earn the contract.
So I think when it comes to the world of drug pricing, pharma and PBMs are sort of the easy villains to jump on, but you said there are 8 people in the middle.
Yeah.
Who are the others that are driving?
Oh, you've got distributors. Well, like imagine this. You pick up, at one point I saw the news, and it was like Cardinal Health and McKesson and everything, projecting something like a 12% increase in revenue due to GLP-1, the weight management diabetes drugs. I was thinking, wait a second. There's something like over 4 billion prescriptions every year in this country. There's not 400 million or whatever, like almost 500 million prescriptions for GLP-1. This is not a 10 to 12% increase in the volume of prescriptions. These are distributors.
Yeah.
Granted, it's a little more complicated to take these drugs and get them from point A to point B than it is to box up a pair of socks and send them to somebody, but not a lot more complicated. UPS doesn't charge you based on the value of the contents of your package, right? Amazon doesn't do that either, last I checked. But somehow it's like normal for a distributor who's basically just moving drugs from point A to point B to get paid based on the price of the drug. Hospitals and physicians like oncologists take big spreads in the prices of the drugs. They'll get it, it'll cost them X and they'll charge Y. So they're pharmacies themselves, the retail pharmacies. So there's group purchasing organizations. Many of them now are captive to the pharmacy benefit managers. But so these are kind of most of the players in the system. But you go through it and like it's amazing how just to a person, to an organization, everyone gets more revenue and more profit with a higher volume of more expensive drugs. And we are changing that for everyone. That's something that's flown under the radar screen. Okay. It's a lot of hard work, but our contracts with hospitals going forward, it's that cost. Oncologists, they don't get to do drug price, they don't get to do spread pricing.
But don't they charge for the actual administration of the drug? I mean, they have...
No, I understand. Yeah, no, I have no problem paying for them for the service that they provide. But they are not profiting off being a drug dispensary. Okay. And right now, it's amazing. I mean, we've had hospitals who literally are marking up the drugs by almost tenfold.
Names, please.
Do that. And so because what we've said to them is, we're not trying to take your overall profit down.
Right.
We will pay you for other things and keep you whole. Same thing with the oncologists, because they derive like half their pay from this spread in drug pricing. Right. But we're not going to let that happen. Now this is going to take years. I mean, these contracts, we often have 3-year contracts. But yet we're going through the whole system, making sure everyone in that system gets paid based on the value that they actually create for the customer. Are you improving the service? Are you reducing the cost? Are you improving the quality? Are we making sure we're getting the right drug to the right person at the right time? I want you to maximize your revenue and your profit for doing that and making it as cost effective as possible and not just, isn't it great? There's a lot more GLP-1 drugs out there. I don't know, maybe it's great, maybe it's not. Who's getting them? Is it really having an impact?
Do you expect more organizations to go down this path that you did, or is it too hard?
Well, I expect once we've been successful with it, it's going to become the norm. Or something along these lines is going to become the norm. Just because not only are we getting like the savings right out the gate, but over time, our trend is not going to match. If you stay with your current model, our trend's not going to match. And the whole world's going to have to shift. Now, I'm not saying pharmacy benefit managers are going to go away, but they're going to have to change their model, as will everybody. I mean, it's not just them, it's everybody in the middle is going to have to change their model, and it's going to get more difficult. Yeah.
Do you expect FTC to do anything? I know they have a very progressive, Lina Khan, who leads that.
Yeah, I think predicting what any government agency is going to do is definitely above my pay grade. So I honestly I just don't know.
Intelligent speculation.
Intelligent speculation? Well, look, I think that anytime, I think there will be activity here. And the reason I say that is because, and I don't think it's going to be limited to pharmacy benefit managers. Okay. And I say that because right now, I mean, we are bankrupting our country with the total cost of health care. We have record deficits at the federal level, even though our economy is on high right now. I mean, there's unemployment's at like record lows, and yet we have this huge structural deficit. We have like our largest debt that we've had historically since World War II. We're actually looking like a lot like Greece was during their financial crisis in terms of the debt to gross domestic product ratio. So at some point, even our dysfunctional political system is going to have to deal with the fact that we can't continue to afford deficits at this level. And when they go look at the picture, they're going to see that over 50% of what we spend every year is on Medicare, Medicaid, subsidies for the exchange, and Social Security. The next biggest outlay is interest on the debt, and then it's defense spending. So if you want to get this under control, you're going to have to bring costs down, which means the scrutiny, like the squeeze that's happening on Medicare Advantage that you see, the scrutiny from the Federal Trade Commission, just political scrutiny, it's just going to keep ramping up. So that's why I say I just think politically the way this lines up, you're going to see action and activity. And anytime you're in a place where the pricing is opaque and you've got a situation like the one we have now in pharmacy where someone told me about 15% of the time, maybe 10 or 15% of the time, the copay that the member pays is higher than what the pharmacy manufacturer nets for that drug. Which you can imagine the scenario where, like, what if there was a 10% copay on this abiraterone, this prostate cancer drug? It would be a $300 copay for the member, and it costs $160. Okay, so stories like that come out and just get the public enraged and politicians enraged. So I think there will be activity, but I don't think that's like the beginning and the end. I don't think it's going to be isolated. I think we're all going to get a lot of scrutiny.
Can we get to the place you want us to get to without single payer? Although there is no appetite for single payer either.
Yeah. Yes, I believe that we can. I loved Sandy Clark, our Chief Operating Officer and our executive owner of this whole initiative. First of all, doing a fantastic job, but she also, I'm going to steal the quote she used at one of our internal meetings from Angela Davis, who said something to the effect of, I've been asked to accept that which I cannot change, and I've chosen to change that which I cannot accept. And to me, that's the shift that has to happen. We're clearly there. Like, we're just like, don't tell me. I get lectured all the time about how things work. We got lectured about this and this whole process but that doesn't exist. It doesn't work that way. Let me tell you how it works. Or like, like with some big oncology groups, but this is just how it works. Like, well, not anymore. And so I think what happens is when we start to be successful, and others, I think, start to say, we're just going to change what we can't accept. It's not acceptable to have like this 10% ad infinitum trend in pharmacy. It's not acceptable to have a model that doesn't center around the consumer and deliver a much better experience. It's not acceptable, for example, for every American to not have immediate access to their records in a digital form. Yeah.
Well, I can't top Angela Davis, so
Okay.
I'm going to open it up for any questions, and I'm happy to repeat the question. But anyone have any questions? Yeah, Sean, go ahead.
Thank you very much. You're speaking our language. Employers and purchasers are 100% aligned. Maybe I'm just going to throw in a little bit of skepticism. You sort of said the question was, are things going to change, right? Is what you've done going to be sort of filtered down to other plans? And I hope you're right. The concern I have is, the big three PBMs are all owned by insurers. You guys are in a unique place where you didn't have your own people. You contracted with people.
Yeah.
So you had a strong interest in changing the game. Why on earth would United Healthcare want to change the game when they're making so much money on their opt?
Oh, I'm not saying that they would want to.
Okay.
I didn't suggest that for a moment.
Yeah.
What I'm suggesting is that, if you show up and you're trying to win business and you're getting out-competed, then you're going to have to shift. And I think the shift you're going to see happen in the pharmacy benefit manager world is they're going to start actually taking on risk for trend. Because they're going to have to do that.
You were talking about competition. I mean, we all thought that the Oscars of the world, the Bright Healths of the world would come in and shake things up. And
I never thought that.
Oh, you never thought. Just the stupid journalist here thought that. Good
Yeah.
point.
No. I mean, yeah. Because, look, I went to the J.P. Morgan conference, and one of the questions I got asked was, I can't remember how many years ago this was, like, which company out there that's really hot right now do you think in a year is going to tank or be in the doghouse? And I said Oscar. And the reason I said that was just not it was smart people, lots of money, but their whole value proposition was we're going to have these really cool electronic tools, and that's what's going to get people to buy our the health plan. It's like, the last time we did consumer research, the top 3 reasons for people buying a health plan was price, price, and price. So you can get a niche from that, but you can't take over and change the world with that as a value proposition. No, I think there are places where you can make a difference. This is one, I think, where It can. It's not going to move as fast as, I mean, I would like this all to change overnight, but that's just not reality. It's going to take a while. But the fact is, when you start going in and saying, when we start treating pharmacy like a cost and a quality center, not a profit and a revenue center, you're going to see the trend separate. And then you're going to have to adapt. And you're already seeing some of that. Oh, we'll do, cost plus, or we'll start. And it's just, I don't think they're going to go away. They're just going to adapt. But they're going to adapt. It's like the innovator's dilemma. Right now, they're right in the middle of the innovator's dilemma. Yeah.
Yes, go ahead, Chris.
So you mentioned this hospital spread for high-cost drugs. And you, as you know, and what I'm used to is when a commercial plan pays a hospital for a high-cost drugs, really common to just pay at a percent of charge, whatever you bill.
Exactly.
On the high-cost. So are you actually going to hospitals negotiating on a drug-specific level? And how are they receptive to it? Or
Okay, well, I can suggest they are not receptive to it. Yes, I am very comfortable with that. No, at the end of the day, I mean, there's different ways to do it, but ultimately it's, I don't want you to have any profit motive associated with it. So whatever cost you're getting for that drug is the cost that you charge us. And now, if we're going to pay you for a service that you provide, and it could be a service associated with the drug, that's different. But we're just, yeah, I mean, it's generally, they have a receipt somewhere. Yeah. It can be audited. Yeah. I mean, this is not rocket science, figuring out how to make sure that's the case. And by the way, I think pharmacy manufacturers are also, between 340B drugs and all these other things, I mean, they're sort of getting hammered politically for the list price. And we've had very good conversations with them. They're pretty eager to try to figure out how to just get rid of all of that and just get a really clean, it's kind of a novel concept. I think Sandy can attest to this, but I don't know, a number of times we sat down, had a lunch, or had a meeting, and we've had to repeat, I don't know how many times, we don't want any fees. We don't want any rebates. We just want to pay. We are paying you for a drug.
That's it.
Okay.
Any more questions? Go ahead.
So I'm kind of intrigued by your decision to say, hey, we'll keep you whole, or we'll pay the same amount. I think, it's kind of like not letting perfect be the enemy of the good. You're saying, all right, well, we're not going to win this one today, but we're going to get it over the course of several years. How did those kinds of discussions go when everybody's saying, well, I need to find savings here and there? Mm-hmm. Why are we going to spend all this effort to put together this entire thing, and I'm not going to get any immediate savings, whereas like a bunch of other things I could get immediate savings?
Well, here's the thing: is we're going to get immediate savings. I mean, we're already getting savings. And I think we're forecasting over $100 million for this year, and ultimately the gross savings annually we expect to be $500 million, and that's assuming that everyone gets, the oncologists and the hospitals get kept whole. So it's not like we aren't generating substantive savings. It's just that, to me, it's I understand we have this really flawed system, and this is the way that they are making income. Literally, oncologists often make half their income. You know this better than I do. Half their income from this drug spread. So walking in and saying, let's cut your income in half, and then let's have a really good network of oncologists. I mean, that's just, I think, a recipe for disaster. And even though we've said, I mean, we almost came to term with a major hospital system just a few months ago. I had to have a direct conversation with the CEO, who was like, but Paul, this is just the way that it works. And I was telling him, we're going to keep you whole. Can you imagine the conversation I would have had if I hadn't even started with that? So we feel like, well, I don't want to be, there's real value. Long term, there's real value in getting those incentives out of the system. I sat in one of these panel discussions like 7 years ago with the CEO of a company that does a test for breast cancer. So the most common form of breast cancer is a genetic test. It's determinative as to whether or not chemotherapy will work or not. And in all of the cancer guidelines, care guidelines, it said you should administer this test before you start administering chemotherapy. So we went back to the claims. They did a study, this company did. In California, 50% of the time it was actually happening that way. Why? It's not like these are awful, evil people. They're not going to get paid unless they're administering chemotherapy. But here we are, half the time, pumping toxins into women's bodies where it could have no effect at all on their health. And so on the quality of health, the quality of patient care, on the cost, if we can just change that system, I know there's value there. And we're already getting administering savings. So I just want these folks to be on board. I want to get that adoption as quickly as possible because there's real value in making it happen.
Well, great. We have filled our souls with great wisdom, and now we'll fill our bellies. So thank you so much, Paul, for doing this with us.
Thank you so much. Appreciate it.